Our next speaker is Dr. Stephanie Graff. Stephanie is the Associate Director for the Breast Cancer Research Center at Sarah Cannon Cancer Center. Stephanie?
Yeah, hey guys.
We can hear you.
Yeah, okay.
Thank
Peggy
you.
told me I could talk about anything I want to as long as it was exclusively about male breast cancer and that I had about 15 minutes. So I'm just going to talk about a little bit about hormonal therapy in male breast cancer because I think in my clinical practice, it's probably one of the things that I see that I wish that most clinicians were more aware of. And so I want you as the male breast cancer community to be really aware of so that it's something that we can all talk about and work together to make sure everybody's receiving standard of care and best practice. So, you know, when we think about male breast cancer, most male breast cancer is hormonal receptor positive breast cancer. So when we talk about hormone receptor positive breast cancer, that means breast cancer that is positive for either the estrogen receptor or the progesterone receptor, or both the estrogen receptor and the progesterone receptor. We still consider, we report those as percentages in a textbook. ER 1% or PR 1% are still considered positive. There's a bit of a gray zone there. Most of us, if it's ER 1 or 2 or 3%, are pretty underwhelmed by that report. But most male breast cancer is very estrogen or progesterone receptor positive with scores well over the 50% mark. And patients, regardless of whether they have early stage disease or metastatic disease, if it's estrogen or progesterone receptor positive, subsequently hormonal receptor positive, are treated with medicines that are designed to disrupt hormonal expression, lowering hormones in the body, and subsequently, I tell patients it's sort of starving the cancer to death, right? That's the cancer's food source, and so by lowering hormones in the body, we're kind of taking that cancer's food source from it. And so the main types of hormonal dysregulatory medications that we use in the treatment of breast cancer in both men and women are either tamoxifen, which is the historical standard of care that is a selective estrogen receptor medicine that targets actually at the receptor, versus the aromatase inhibitor, which targets the conversion of estrogen into its more active form. And so the aromatase inhibitors are medicines like anastrozole, the brand name is Arimidex, letrozole, the brand name is Femara, or exemestane, and the brand name is Aromacin. And then another group of drugs that you'll hear me talk a little bit about as we go through this are the Gnrh analogs or antagonists, which are medicines like Graff or Zoladex or Lupron or Lupride. And those are medicines that block our hormonal manipulation at the highest level up in the brain. So for women, particularly postmenopausal women, our standard of care has become to use the aromatase inhibitors. And that's because of a trial by the Early Breast Cancer Collaborative Trialist Group, published in, well, the Lancet in 2015 was the follow-up study looking at the 10-year reported outcomes that showed that there was an improvement in aromatase inhibitors in reducing both recurrence and risk of death for the aromatase inhibitors in postmenopausal women compared to tamoxifen. In premenopausal women, tamoxifen remains the standard of care, but for premenopausal women with high-risk disease, we talk about adding those Gnrh analogs in order to basically make a premenopausal woman, postmenopausal woman, effectively turning off their ovarian estrogen production, and then we can use the aromatase inhibitors to get them that added benefit that we see in postmenopausal women. So the problem is that in men basically behave like premenopausal women. And so for men with breast cancer, if we treat them with the aromatase inhibitors alone, we are not able to adequately suppress their estrogen levels. And the reason for that is that men have a dual control center for their luteinizing hormone because, you know, the human body is really elegant in that everything kind of feeds back a loop. So, you know, our body says we're hungry and it releases all these hormones that go to our brain that release saliva and release digestive enzymes. And then we start eating and gradually those hormones get turned off as food starts to drop down into our stomach, right? Well, the same thing's happening in our hormonal body where your body needs these hormones and gradually they get released. And so chemicals start to go back up to the brain and say, okay, the hormones are being released. We don't need as much hormones anymore. Start to dial it back. And so for men have both estrogens and testosterone, and medicines like the aromatase inhibitors turn off the estrogen loop, but not necessarily the testosterone loop. So when we use an aromatase inhibitor to suppress estrogen expression, we don't turn off that negative feedback loop in the testosterone circuit. And so men's estrogen levels aren't fully reduced. And so in the Journal of Clinical Endocrinology in 2000, they did a study where they gave anastrozole, a generic name, to men, and they saw that it only reduced their estrogen levels by about half rather than fully. And so it showed us that estrogen or anastrozole or aromatase inhibitors alone probably aren't effective for men. And now there's been 2 studies that looked at men treated with aromatase inhibitors as compared with breast cancer as compared to men treated with tamoxifen with breast cancer. The first one was published in 2013 in the Breast Cancer Research and Treatment Journal, and it was a population review from Germany, and it looked at 257 men with breast cancer. Out of those 257 men, 50 were treated with aromatase inhibitors, and the remainder were treated with tamoxifen. It was not a randomized study, so we don't know why the 50 men that got aromatase inhibitors got them. There's a chance that maybe they were sicker or maybe they had worse breast cancer, maybe they had risk factors that made giving them tamoxifen. Tamoxifen increases the risk of blood clot, so maybe they were high risk for heart attack or stroke that made them higher risk for other problems. I mean, these are all sort of confounding factors that we don't know or understand. But in that study, what we saw was that there was about a 1.5 increase, so 1.5 times increased risk of death when the aromatase inhibitors were used in men with breast cancer as compared to tamoxifen. Subsequently, there was a follow-up study that in 2010 that looked at the SEER database, which is the United States database of 512 men with breast cancer, and compared tamoxifen to aromatase inhibitors, and it saw no decrease in mortality for men treated with aromatase inhibitors. So treating a man with an aromatase inhibitor didn't really seem to help. So what I want to communicate and make sure that men living with breast cancer know is that it's not that aromatase inhibitors are bad or ineffective treatment. It's that they have to be combined with those medicines that fully turn off that cascade. So when we treat a man with an aromatase inhibitor with breast cancer, it needs to be used in combination with a Gnrh analog, so a medicine like Lupron or Zoladex, that turns off that feedback loop at the highest level. So it kind of turns off that hypothalamic feedback loop like you're a premenopausal woman. And so for a man that's had metastatic disease that's progressed on tamoxifen, or a man with early stage disease that for whatever reason is not tolerating tamoxifen, it's important that if we switch them to an aromatase inhibitor, that we are doing it in a safe context and using it in combination with a Gnrh analog. The Gnrh analogs in women, so we use Gnrh analogs to treat prostate cancer. And in the prostate cancer setting, in men, there's a depot shot that's given once every 3 months that seems in men to be pretty effective at controlling prostate hormone levels. In premenopausal women, we do not use the 3-month depot shot because it's not adequate to control premenopausal women's hormone levels. So for premenopausal women with breast cancer, we have to give them monthly injections. in order to adequately control their hormone levels. So I've erred on the side of caution in the limited men that I've had to give that shot to, and told them that it would be my preference to continue to treat them monthly, which is yet another burden for a man with breast cancer to have to commit to a monthly injection in addition to their daily pill. But I think given the paucity of data that we all live with when we're living as a man with breast cancer or treating a man with breast cancer, I'd rather err on the side of being cautious. And I think that it's something that we just don't talk about very often. Most of the clinical trials that are designed now, I mean, all of the CDK4/6 inhibitor trials that were used in combination with aromatase inhibitors accepted men, but all of them did include Gnrh analogs in combination for men, which was smart trial design. And so I think that you'll see that if you read sort of the fine print of how these drugs are being studied in men, that's the recommendation. But I don't know how far out into the reaches of the world that information filters. And so I think it's really important that we continue to discuss it and talk about it as a community so that it is in our conscious. And that's everything I'm going to say, and take questions.
Thank you so much, Dr. Graff. We appreciate you. Dr. Jay Harness has a question here.
Well, I've got a question for both Stephanie. That was an outstanding presentation. What a great overview. And then Ben Parker, if you're still listening over there, I've got a thing for both you and Stephanie. Stephanie, I'm a breast cancer surgeon with about 35 years of experience in the field. And I'm working with the American College of Sports Medicine on what's called exercise oncology, adding exercise as the standard of care for breast cancer patients. We're working at the national level with National Accreditation Program for Breast Centers. My question to you is, and Ben, the same to you as well, in your programs as medical oncologists, are you advocating strongly or at all for exercise for our breast cancer patients during therapy, post-therapy, et cetera? But again, a great presentation. Thank you.
Yeah, we do. We actually have a cancer certified exercise therapist whose name is Sammy, who is fantastic, who has an exercise program developed in our for our patients, both our breast cancer patients and then our cancer program at large, both for weight management and then also a plethora of other issues. I think there's a pretty clear emerging data that exercise actually reduces lymphedema risk, not increases lymphedema risk, which is a turn from the sort of urban myth of old. Then clearly weight reduction is favorable for everyone living with breast cancer because it reduces the risk of recurrence and improves outcome. Exercise improves fatigue. Exercise improves muscle tone, which is good for everybody. So there's lots and lots of benefits. The American Society of Clinical Oncology does have guidelines around exercise. I think they're soft. I mean, they say things like you should exercise. They don't say like specifically what or how or which is better than nothing. But I think that there's lots of room to be more specific. But it's hard to give a very specific recommendation to a large population. And so having a program and a person like Sammy that you can individually refer patients to so that they can kind of meet somebody where they are, I think is powerful.
Yeah, I would add to that and amplify that. We are, both when I was at Hopkins and at Vanderbilt, very much into, probably many of you know the term survivorship, but would extend that beyond, because a lot of places survivorship means patients who are at early stage and they're continuing on, but even in metastatic patients too, where particularly in breast cancer, where we have so many therapeutic options that can lead to really long-term progression-free survival. And so I think what we've tried to do is actually pair up our patients with various organizations, various types of programs. There's a great one here called ABC for After Breast Cancer that's funded through Komen and our local WISE that's free for patients. But it really takes, again, a more holistic or overall approach to patients for both diet, exercise, but also mental well-being. I think that's another thing that we have learned as a field, that beyond maintaining ideal body weight, eating healthy, that reducing stress and also making sure that, you know, your kind of balance between not having to constantly worry about, is it my breast cancer coming back, is it progressing, and living your life is actually therapeutic in many ways. Some of the earlier studies looking at this for depression, for example, some of the value and benefit is almost as much as any type of systemic therapy. So we have really tried to push this forward, that we need to treat our patients beyond giving therapies like surgery, radiation, and systemic therapies, but really also diet, exercise, and again, mental health.
Hey, Ben, thank you very much. I owe you a phone call, by the way, from when we did that joint session several months ago.
Yeah,
But
I remember.
there are a number of clinical trials, like close to 1,000, that show the benefit of exercise for cancer patients. Both of you are obviously doing the right thing, but we just need to get this incorporated more and more into cancer center efforts, both short-term as well as long-term. But your comments were really spot on. Thank you both.
So, Dr. J, I'd like
We
to
have a question. Oh,
This is Rick Davis, because this is a subject that is really near and dear to my heart. Going back to 2008, when I was placed on 2.5 years of hormone therapy for prostate cancer. The first thing I want to say to Dr. Graff is that if you innovate the use of LHRH drugs for male breast cancer, you must incorporate a really good education program with that. And don't make the mistake that so many of the doctors who prescribe hormone therapy for prostate cancer have done, which is just put a man on an LHRH drug and not tell him what to expect. We spend a lot of time educating men and working with men to help them combat combat ADT drugs as well as androgen blockers. But the androgen blockers aren't as serious because they're not necessarily taking all of the testosterone out of your body. Now, I want to just go to the exercise, because the exercise is really, really key. We innovated a program back in about 2009 or 2010 at UCSF that does exactly what you're doing now, Dr. Graff, which is to create a referral, a clinical referral to an exercise counselor. And we initially wanted to do that to help men who were on androgen deprivation therapy, but in fact, the program got innovated for the whole of UCSF Cancer Center, Comprehensive Cancer Center, and it's still in operation, and the patients love it. And what happens is that if a patient needs an exercise consult, it's available to them for free, and the exercise counselor then refers them onto an exercise program and acts as a cheerleader to help compliance, and it's shown very good compliance. We've tried to innovate that program in other centers. We just don't have the funding. We haven't had the success, but we're always open to doing it because we know it works so well. So to answer Dr. Harness, exercise is hugely important, I think, in treatment. I mean, I speak as a layperson, but I speak as a layperson of experience. And we know exercise is so important. I mean, way back in 2008, all we had on exercise studies for cancer was Melissa Irwin's work for breast cancer and lymphedema. We didn't have anything more. And look what we have today for so many different cancers. And I personally, and ANCAN and Medifit, we started a program called Medifit. I'll put the URL in the chat window. Have really tried to be a catalyst in innovating exercise. I'd be happy to follow up with you offline at any time.
Rick, I'm already working with Reagan Frederick and the Sunflower Group and whatever, so you'll be pleased to know that, okay?
Oh, yeah, well, they know me. We went our different ways early on. You probably don't know that, but it was only because of the work that I did that we got Reagan back into UCSF, and I love Reagan.
Yeah,
I love
do
Reagan,
too.
so
He's
reach
fabulous.
out to me. I'll fill you in.
All right, good. I will reach out. Thank you.
Thank you. Dr. Lopa has a question.
Yeah. Yes. So, Dr. Harness, thank you so much for bringing up exercise, because again, it ties back to inflammation also. Like exercise kind of downregulates the inflammatory pathway in the body, which is equally helpful, right? Because we know what role it has to play with the cancer progression. And thank you, Dr. Graff. It was a great presentation. And I just have a question. Like, I know you are mentioning about the combinational drug therapy with all the targeting the hormones. So do you have anything published yet which can become like a data source for people like other oncologists all across the US and even like in the developing countries, because there's so much discrepancy with the treatment protocol with male breast cancer. So any resource from Dr. Park, Dr. Graff would be really helpful if we can have it, because when I'm meeting oncologists and even they are at loss because there's so many less male breast cancer patients, because you both have been working so much on this, and even Dr. Harness can bring it up. So if there's any place where I can recommend the doctors I meet on the way during my outreaches, that would be a great help for the community.
Everything I talked about is a part of the NCCN guidelines. So they can, it's all, the NCCN guidelines has 2 pages. It's only 2 pages out of what, like 150 on breast cancer, but there's 2 pages devoted to male breast cancer that includes everything I said. So that should be available. And I see that Alan's question popped up.
Yes.
So with metastatic ER positive metastatic male breast cancer with disease progression on Lupron, Letrozole, and Ibrance, when somebody progresses on a CDK4/6 inhibitor that's hormone receptor positive is when I typically consider genomic profiling. So that is when I would do something like Foundation Medicine or Garden 360 to look for an actionable mutation. There are numerous clinical trials right now looking at everything from ESR1 mutations, FGFR1. I could talk for hours about emerging drugs in development, but that's a really good time to consider profiling to look to see if there's a clinical trial that you would be open for. If you do not match a clinical trial at disease progression on a CDK4/6 inhibitor, there is data to support Faslodex, or fulvestrant is the generic name, for men with breast cancer. It's a small study, like 80 men, but good efficacy with similar disease progression-free survival as seen in women. So I think fulvestrant is a good option for men. After progression on fulvestrant, and fulvestrant could be given in combination with Piqray if you had a PI3 kinase mutation identified on your genomic profiling. It could also be given in combination with Afinitor which is everolimus, if you did not have an actionable mutation on profiling. And after that, I think you're looking at more traditional chemotherapeutics, probably capecitabine, Xeloda, that's brand name, generic name, or IV medicines like Taxol and beyond.
Okay. I know Alan has questions there.
And Antonio, you need to talk to your doctor. Push hard.
Antonio, that's an answer to your chat here. We've got all in the chat window. But that is good. Ron, you had a question?
Yeah, I have a question for Dr. Graff. Great presentation. It's actually a 3-part question. Has there been any studies about reducing the dose of tamoxifen from the standard 20 milligram to maybe 10 milligram to reduce the side effects? And the second question is, why did they move it from 5 years to 10 years? And the third part is the blood clotting issues. Do you recommend for men on tamoxifen, if they're going on travels, for example, on an airplane where they're sitting for a long time, do you recommend they go on anticoagulant therapy for that specific time frame?
Great. So I'm going to maybe do those in backwards order. There's really limited data to suggest that any antiplatelet or anticoagulants are beneficial in reducing the risk of thrombotic complications on tamoxifen. Even, I know that it's not uncommon to hear oncologists recommend tamoxifen, but the data to support that helps you, the data to support that that's beneficial is sparse. Other things that increase the risk of clotting is, of course, smoking. So don't do that. It's bad for you. And dehydration actually really increases the risk of clotting. So I always encourage patients that if they're going to be doing prolonged travel or prolonged immobility, to make sure that they're staying hydrated. I think it's hard especially now with all the mask wearing and with like airlines not letting you bring water through security, like it's hard to drink enough when you're traveling. But try to be conscious about making sure you're having enough water when you're traveling if you're on tamoxifen. In terms of why did we move from 5 years to 10 years, we did do a study that looked at extending tamoxifen from 5 years to 10 years. So there's like the body of evidence is now 5 years of tamoxifen followed by 5 years of an aromatase inhibitor, 5 years of tamoxifen followed by 5 years of tamoxifen for a total of 10 years of tamoxifen, 5 years of an aromatase inhibitor followed by an additional 5 years of an aromatase inhibitor. And all of the data has said that 10 years is better than 5 years, but all of the benefits have been small. So all of the extending to 10 years, whether it's a switch therapy or a same therapy, have been small benefits in the range of 2 to 5% points. And so what I tend to tell patients is it depends a little bit on how bad your cancer was, and it depends a little bit on how well you're tolerating the medication. So if you had 37 positive lymph nodes, I'd probably take it for 10 years. If every single morning you wake up and you hate that damn pill, I'd quit taking it, because is a few percent points worth another 5 years of feeling miserable? Probably not. But if your risk of your cancer is already really high, are those extra percent points going to be beneficial for you? Probably. So those are the sort of decisions that you're going to have to make. And hopefully your physician can have a more nuanced discussion with you about your actual risk based on your cancer and your staging profile. The third was the data around a lower dose of tamoxifen. So when tamoxifen was originally developed, they did do studies looking at 10 milligrams twice a day, which is obviously the same dose as 20 milligrams once a day. And so I do actually sometimes prescribe 10 milligrams twice a day for patients. And some of my patients, particularly patients with a lot of hot flashes, do better on 10 twice a day rather than 20 once a day. So that's an option. There was a trial from, oh goodness, now I'm not going to remember where. It was presented at San Antonio in 2018. And it compared 5 milligrams of tamoxifen to nothing for DCIS. So it wasn't comparing 5 to 20, it was comparing 5 to nothing. And the 5 milligram of tamoxifen compared similarly to the historic reported data for how 20 milligrams of tamoxifen did for DCIS. Now, DCIS is a different disease, obviously, than invasive breast cancer. And to say that you can extrapolate one small study to the invasive, that's a lot of sort of cross-trial comparison that puts us in dangerous water. But you know, for patients that are really tolerating endocrine therapy poorly, something's better than nothing. And a lot of the times we just have to meet somebody where they are and kind of dance through what's going to feel okay. And I mean, Peggy typed in here that Brett took Arimidex by itself for 10 years, and obviously he's thriving and doing great, and, you know, is no evidence of disease and forever and ever, knock on wood.
Yeah, he took it for 5 years because Tamoxifen was a mess for him.
Yeah.
And I had met at San Antonio, I met the actual scientist, him and his wife, who had developed Tamoxifen. And he came to the booth and talked about how it does. He developed it, but didn't think it would work well in younger people. That's exactly what he told us.
I mean, and so that goes to the point. Arimidex by itself in men lowers hormones by half, maybe a little bit more, maybe a little bit less, and is half better than nothing. Absolutely. You know, so this is all, I mean,
each person's different, and it's trial and error. That's what it comes down to.
But if we're following our best, that's where our current guidelines are.
Yes.
Can I just, for Dr. Graff and anyone else, I put the link into a hormone therapy pamphlet that we wrote in 2010. It's been updated since then, it's just a really, although it's prostate cancer oriented, it's going to be really helpful for any man that you place on longer term hormone therapy, just to give them an idea of what's going to happen. That's why we wrote this years and years ago, so it may be useful to you. It's a UCSF Your Health Matters pamphlet.
Wonderful. Thank you so much. All right, so Dr. Graff, thank you so much for your knowledge. We appreciate it all.